Hello, I'm David Canzeri, Director of Interventional Cardiology and Chief Scientific Officer at the Piedmont Heart Institute in Atlanta, Georgia. And welcome to this program entitled Renal Denervation Rises from the Ashes. Joining me today at the ESC here in Barcelona is an esteemed collegial panel of experts in hypertension. And we're first joined by my friend and colleague, Dr. Michael Bohm. Michael is the cardiologist in chief, Director of the Department of Internal Medicine 3 in Saarland University in Hamburg, Germany. Welcome, Michael.
Thank you.
And secondly is Franz Messerli, from the Department of Cardiology at the Bern University Hospital in Switzerland, the Department of Cardiology at the Mount Sinai Health Medical Center, and the Jagiellonian University in Krakow, Poland. Franz, great to have you here. Thank you.
Hi, David.
And finally, another great friend, Roland Schmieder. Roland is in the Department of Nephrology and Hypertension at the University of Erlangen in Erlangen, Germany. Welcome, Roland, and welcome to our audience as well. In this program, we'll be talking about renal denervation, where we've been and where we're heading, and some very important clinical trial data presented today as a late-breaking study here in Barcelona. But I'd also like to mention that we'll be discussing the use of novel investigational devices that at least to date have not yet been approved in the United States. As a background, hypertension, of course, is the leading contributor to morbidity and mortality worldwide. And in particular, for patients with hypertension, the prevalence has remained steady over time. But if anything, the number of patients who have achieved control, who are prescribed medications, perhaps even health practitioner awareness, has plateaued, if not declined. Perhaps the editor of the journal Hypertension once best stated that of all the more than 100,000 patients included in a clinical trial, no matter what matters is lowering the blood pressure, however that may be achieved. And typically we assume that was with pharmacology, but perhaps we could add medical therapy or device therapy to that as well with renal denervation. Historically, we embarked on a randomized trial, the Hypertension 3 study. This was a large pivotal trial in the United States in a very different treatment population, Michael, that I expect you'll address, of patients with severe treatment-resistant hypertension. The study did not achieve its primary endpoint of efficacy, although being a safe procedure. And since that time, then, we revisited renal denervation in many different ways, from a preclinical aspect of understanding the anatomy, of understanding how we do the procedure, of redeveloping the technology, revisiting the patient population in whom we study, and finally revisiting how we do these types of clinical trials. And that leads us to the SPIRAL program, the off-meds program of which you presented today. So please share with us those results.
Yeah, the SPIRAL program was designed on the basis of what has been done on HTN3. So we moved away from the drug-resistant hypertension with more than 5 drugs to an untreated population. To look at an untreated population with moderate hypertension and elevations of blood pressure, they had to fulfill certain blood pressure goals, which is in between lower than 180 and greater than 150 in office blood pressure. And the primary efficacy endpoint was ABPM because it is less associated with placebo effects. Another thing to go to which has been learned is to improve the technology. So there is a new device which is a spiral catheter which allows circumferentiality of the ablation procedure. Furthermore, this is a PTCI wire-guided device which allows entry into the branch arteries. And experimental studies have shown that the nerves, the sympathetic nerves, are in a more close vicinity the more it comes to the periphery. So this was one reason to go to the main stem and also to the branches. And with this approach, it was shown that we can reduce the scatter and also have a more profound reduction of kidney norepinephrine content in experimental approach. So this is the second change. And the third change and argument in favor of using a non-treated population is that this is not confounded by medical treatment. And furthermore, we tested whether these patients are really off drugs by urine and serum testing before we went into the trials. So this trial was designed in order to have the basis to design a pivotal trial later on to an appropriate power calculation for this pivotal trial. And these patients were then assigned to a sham control group. These patients were, as an HTN3, completely blinded to the procedure with a highly significant blinding index. So with a high level of reassurance, we can say that these patients are really blinded to the procedure. And then the parallel group was renal denervation. The follow-up was approximately, and that was not approximate, was 3 months with follow-up visits also for safety every 2 weeks. And at 3 months, again, patients were checked whether they were off medication, and office blood pressure and ABPN was taken again. So the results of this trial were that there was a drop in systolic blood pressure, ABPM, of 5.5 millimeters of mercury. Placebo-controlled, it was 5 millimeters of mercury. There was a statistical significance in the renal denervation arm, but no statistical difference in the sham-controlled arm, and similar findings were observed for diastolic blood pressure with a placebo-controlled difference of 4 millimeters of mercury. Again, it was highly significant. On office blood pressure, the drop was 10 millimeters of mercury. In the renal denervation group, there was no significant drop by 2 millimeters, 2.3 millimeters in the sham control arm. So placebo controlled, a significant difference of 7.7 millimeters of mercury. And again, a significant drop of 5 millimeters of mercury diastolic and 0.3 in the sham arm, which was not statistical difference, again translating into a significant difference between the two arms. So what we conclude from here, this is the first trial which have shown in a placebo-controlled way that renal denervation works, so that the principle of addressing the sympathetic nervous system in an untreated population reduces blood pressure. Interestingly, we could not see any complications, which is very important because the interventional approach was more intensive than in any previous trial, addressing the branches, going thereby to smaller vessels. The minimal size of the vessels was 3 millimeters, so we are in the range of coronary arteries here, but still there was no bleeding, no dissection, as far as we can say here from this 3 months of follow-up. So therefore, the shortcomings of the trial is that this is not a pivotal trial, so we are now able to design the pivotal trial, and of course we will need to show whether the pivotal trial is positive. We have another twin trial running, which is on medications with fixed dose combinations of 2 and 3 drugs. Again, there will be a testing of drugs before we go also with patients on medications to the pivotal trial.
So Michael, in many ways, as you say, this is a feasibility study, not by any means a pivotal trial. The results are not ready for routine clinical practice, but by any means, but it's informative on how we move forward, perhaps with a randomized clinical trial. Just take a moment too, before we broaden our discussion with Franz and Roland here, to share with us how this trial differed in many ways from the HTN experience, just with regard to some of the measures like blood pressure, procedure, treatment, etc.
So the first thing which has been changed, this is all based on the analysis we have done on Simplicity HTN3 and also in registries, is the medication. So this is the off medication because we did not want to see confounding with medications. In HTN3 there were about 5 medications, 5.1 at average, and there was no testing of the adherence. So it is likely that there were in-dropping medication, and the huge drop of the blood pressure in the sham group is slightly arguing in favor of the suggestions. The other thing, we looked into the patient population. In HTN3, many patients had resistant, much advanced hypertension, and a certain portion of patients had isolated systolic hypertension. And it has been shown in HTN3, but also in registries and other previous trials, that these patients are hyporesponsive for renal denervation. So the exclusion criterion in the spiral study is blood pressure, diastolic blood pressure below 90, in order to exclude those patients. And the third thing is that indeed the device is different. This device is adjacent to the whole circumference of the artery. There is a simultaneous delivery of 4 points with energy to the renal artery, and then it is repositioned. And therefore, there is circumferentiality. It's a different device. Furthermore, experimental data, as I've mentioned before, have shown that this is very important to go to the periphery because the nerves are in more close vicinity to the lumen of the artery, so more nerves are accessible. And this could be shown in animal studies that this is the right approach. So the result of this changed technology is that in Simplicity HTN3, about 11 ablations per patient were performed. And here we had about 43 ablations. So there is four times more ablation points. In spiral, this might be important. And also these ablations in about 2/3 of the cases were in the branches where the nerves are better accessible. So I think these are the main changes which also might teach us for future trials how to go.
And Franz, part of the discussion after Michael's presentation today has been putting this in the context of clinical impact and clinical meaning of the blood pressure reductions. In general, roughly a 10 millimeter systolic blood pressure reduction, a 5 to 6 reduction in ambulatory blood pressure systolic measurements. And how do you interpret that magnitude of measurements in terms of clinical meaningfulness and just thinking about this if translated to a broader population in clinical practice?
Well, let me put it simple. Any blood pressure reduction can be clinically meaningful, but we need to consider that blood pressure is a surrogate endpoint. And not all blood pressure reduction will automatically translate into a reduction of heart attack, stroke, and death. And this is actually what we do want to achieve. Now, when you look at antihypertensive drugs that interfere with the sympathetic nervous system have not a very good record in reducing morbidity and mortality. Diuretics are very efficacious, but they actually increase the activity of the sympathetic nervous system, and so do the calcium antagonists. So the big question here is, yes, the blood pressure goes down, no question about that. These are provocative results, very impressive, but will they ultimately translate into a reduction of stroke, heart attack, heart failure, and death?
I think, well, let me add, in the meantime, of course, we have to deal with blood pressure. And when I look at the most recent meta-analysis that has been published in The Lancet last year, including the controversially discussed SPRINT study, it has been shown that 10 millimeter mercury decrease in office systolic blood pressure translates into 20 to 30% decrease of cardiovascular complications, such as stroke, development of congestive heart failure. So this is roughly what we can expect, and we have just seen a 10 millimeter mercury fall, of course, in office blood pressure, including the 2 millimeter mercury, which may be placebo effect or not, but it doesn't matter for the patient. If it's 10 millimeter or less, we can expect, and that's a hypothesis at least, that we have also an improvement in cardiovascular outcome.
For all of you too, despite the number of pharmaceutical agents that are available for the treatment of hypertension, there's still a very broad population of patients with uncontrolled hypertension, however we characterize it or define it. Part of the contribution of that is patient adherence to medications too. And in this trial, Michael, as you said, this is an off-med study, but we were monitoring adherence off medications, and yet a small fraction of people still took medicines, and it raises the challenge of these trials. But you and Roland, I know at least, have a great experience in prior renal denervation trials of monitoring adherence, and in some instances, complete adherence was at best 50%. And so, what is your perspective about the potential? And again, I emphasize the potential because we need to do a pivotal trial with this therapy. But what's the potential of this therapy, either complementary or alternative to medical therapy?
So I was very concerned before we started the trial that we could not find patients who are off medications and undergo or embark on this trial with a 50% chance to go to a sham controlled arm. And I was wondering why indeed patients were coming, sometimes on drugs, sometimes without drugs, and for the reason they do not want to take drug. I think this is a number of patients which is very underestimated, and the non-willingness to take drugs might contribute to the high non-adherence rates. So therefore I think there is a chance that we can offer a patient a third option when the pivotal is positive, in order to show that there is something beyond lifestyle, beyond medications, and maybe it's the third option. And I think the patient wish, which needs further extensive discussion, of course, might play a role in the future.
It's important to recognize, too, that we're doing still to date a near completion, a feasibility trial like this against the context of medicines, against the background of medicines, and this will, I think, help position or inform the role of this therapy as well. Franz, do you have a comment?
Yeah, Michael, do you think by offering a patient who does not want to take medication this procedure, you can postpone the time point when he or she actually will have to take medication for months, years, or decades, or what is your gut feeling here?
We need gut feelings, a lot of gut feelings.
The gut feelings.
I mean, this is no speculation. The first thing is that indeed, hypertension is a progressive disorder, and maybe the majority of patients might not escape from taking drugs. What will happen now after we have reported these first results is there will a controlled up-titration scheme after 3 months. So this provides us with the information whether the presence of renal denervation might reduce the drug load. Yeah. So therefore we will see whether patients need less drugs to get controlled when they have had before a renal denervation. But we need here more data in order also to look at the point whether or not this is cost effective and whether this will work. Yeah. How long it will take to get patients out of the medication area, I don't know. I'm more positive and optimistic that we might save some medications.
But I think the point is well taken that if you have an intermittent therapy, and we, let's say for a year or so, or for 2 years, we know that from drug trials, that then you make stop medication if the patient in the beginning is in the early stage of the hypertensive disease, because you can expect some reversal of the vascular changes. And also in the trial, I'm very eager to see now in these patients whether the blood pressure fall will go further down in those who do not need any additional medication.
Yeah, well, we cannot really see it because this is an interesting.
No, I mean usually beyond 3 months. If you go to 6 and 12 months, but a progressive decline which has been observed.
It has been observed. We will not see in this trial because from 3 months we allow medication, so we do not have a spontaneous time follow-up of blood pressure after renal denervation. But you are right, in all the hypertension trials, HTN1, we've seen that it is further progressing the decline in blood pressure, but now it may be a little bit accentuated because we give drugs.
Actually, Roland, we have done a paper together. You were the first author in JAMA just about 20 years ago. And looking at the predictors of maintaining normal tension after antihypertensive therapy was stopped. And actually some of these patients remain normal tensive for up to a year and more.
Right, up to a year
and
more.
And the predictors are the usual ones, but
young age, early stage of hypertension, that was the most important one. And this is of course hope, But on the other hand, we should not overstress the data, but it's a nice speculation to see that if we have another tool to treat hypertension, and maybe in particular tackling the sympathetic nervous system, which is a driving force of the progression of hypertension, according to so far we know, that it might be a very good option for some patients.
Well, in the spirit of speculation then, too, if we could expand these results further, perhaps at least with that gut feeling, as you described, Michael, is that one of the other considerations would be how you would perceive a device therapy like this, or maybe others in clinical practice. And like most other device therapies, it seems device therapies are complementary to medical therapy, not typically at the exclusion. One of the issues, too, that was raised in the presentations today is getting patients to goal blood pressure and how often this was achieved and what these differences really mean. And while I think we would all agree that getting to goal, whatever that goal may be, is important, even modest reductions from higher levels to lower levels, 160 to 150, 160 to 145, that may be above the goal per se, but it's still very meaningful for the patient. Is that not correct?
I think we are coming to the point which Franz is making about preference of the patient, what he actually wishes what to do. Right. I think there might be some patients who are afraid of having a pill burden for the rest of their life, and if they can, let's say, minimize or decrease the pill burden, this may be for some patients really their wish, and it comes into that effect that we need to know more about patients. I cannot speculate how many % would prefer another drug or let's say another option?
Yeah.
I don't know. We don't know these numbers at the moment, but this is an open question.
Actually, it's very simple. Whenever I see a patient or you see a patient, and you can combine two pills into one, patients are very, very grateful. Oh, I will have to take a pill less, right? So this is important.
Yeah.
Really.
I agree. I think that theoretically this might be a therapy that in rare selected instances it would be an alternative to medicines, but perhaps more commonly it would be either reducing the medication burden, as you say, Michael, will survey in this trial, or as an alternative to additional medications as well. Let me also ask you too, Michael, what and for all three of you and your experience in hypertension clinical trials, how does this patient population differ from other hypertension studies? Is it a more eager patient population? Is it, like you say, the patient population that really isn't interested in adherence to medicines? Is it a younger patient population? This is a recruitment for a trial like I've never been part of before.
I don't think it's specific for a hypertension trial. We see the same things in heart failure trials. Patients who are embarking on trials are more open-minded, I have to say. And also there is an analysis in heart failure that patients agreeing to take part in a trial compared to a matched population who did not take part in a trial have a better survival. So they are more interested in medical interventions. They are more open to medicine. So therefore, I think this is indeed a special population. But this relates not only to hypertension patients. This relates also to heart failure patients and other populations. But we will see. Therefore, it is necessary, in my view, that we will have a registry afterwards how the procedure is doing in real life practice, as we have done with the previous device, with the Simplicity Global Registry, which is very important also to see what physicians decide whom to treat. This is another thing which is important. So this, I think, will come.
In that respect, I was very pleased to see that the drop in medication, patients who are not adherent to the protocol and took on medication, either the previous one or the one from their wife or neighbors or whatever, that this was equally distributed in the sham group and in the treatment group.
Yes.
And that's an important issue because these patients, well, they want to get their blood pressure treated, but it was equally distributed. It has been also in other trials. And that's reassuring that we have really a rigorously conducted trial.
And Franz, let me ask you, as Michael described, this procedure was also done with a different technology and in a very different way than what we've done before, extending renal denervation into the branch vessels of the renal architecture, the vasculature. And in your perspective, is that a big game changer, or do you think is there going to be now a class effect of all radiofrequency therapies for denervation?
I don't think there's a class effect. I think this specific approach is one that is working. We know that now. So we actually have to learn from this approach and extrapolate to the other ones. So I think this is the way to go.
Well, in our final moments, just with Michael's presentation, and Michael, I'm going to ask you this as well, but when you first saw the data today for Michael's presentation, Roland, what was the most striking takeaway that you had from this?
Well, just two words: it works. You know, this is really a proof that renal denervation is effective in reducing blood pressure, and it has been done with 24-hour ambulatory blood pressure, which now is considered to be the gold standard to analyze any antihypertensive efficacy. And if we allow me the comparison to a drug development, we are now in a phase 2 drug development. It works in patients with a certain disease, in this case hypertension. And now we need to move on to the next step, phase 3. More patients, broader in inclusion criteria maybe, and then also to filtrate which are the patients who profit most from the from renal denervation. But that's the next stage, phase 3, which is now the next step.
And one more little point. What's the most common antihypertensive drug used in the United States and everywhere? It's hydrochlorothiazide. And it works just as well as hydrochlorothiazide does in terms of millimeters of mercury as measured by ambulatory 24-hour blood pressure monitoring. And
I just learned that hydrochlorothiazide is the worst of all with respect to adherence. It has if you have a thiazide diuretic, the non-adherence is one determinant in a large study which has been presented.
Franz, I'll ask you the same question as for Roland. What was your biggest takeaway from the presentation?
Well, again, I think it's a matter of principle. This is the first time, actually, that for a sham-controlled trial, of all the sham-controlled trial, PFO and so on, that there is one that actually shows a positive result.
Yeah.
All the others have always been negative. So to me, that's very impressive.
And Michael?
I can echo that. I mean, it's a sham-controlled trial and an intervention which is unique. I think I'm not really aware of any other trial, sham-controlled, which indeed has shown superiority. And the other thing, I was very pleased to see the table with so many zeros when it comes to complications, although this is a very active and intensive denervation strategy we've performed, but there was not one dissection in this group of investigators. So the device is important. Every device should be looked at separately. It has to enter the branches, which is not the case for every device. And safety is an issue. So proctoring of investigators and using the appropriate device is something which is, of course, necessary.
Yeah, like you, when I first saw these data, I felt that in many ways this was a validation of how far we've come since the HTN-3 study in revisiting our understanding of this procedure, of the pathophysiology of hypertension and its relationship to the sympathetic state. And even in HTN-3, we had seen some individuals who clearly derived a sustainable benefit. And the question was, how do we demonstrate this in the context of a clinical trial amidst all of the other confounders and variables in that trial experience? And this was really an affirmation of everyone putting it together and seeing the end result, and a safe one too, as you mentioned. So Roland, Franz, Michael, congratulations again, and I want to thank you all for being part of this program. I want to thank our audience too for participating in this activity, and please continue on to answer the questions that follow to complete the evaluation. Thank you again for being part of this program.